It's a very interesting talk which we are going to hear from Professor M.V. Padma Srivastava. She is the head of Neurosciences Centre at the All India Institute of Medical Sciences, AIIMS in New Delhi. And Dr. Padma is also one of the most passionate champion of the cause of enhancing the stroke care in our country. So we had an opportunity to work with Dr. Padma for some time to spread more awareness on stroke, which kills and make a lot of people disabled in our country. So the next talk is going to be on COVID and brain, and I'm sure that it is going to be an interesting the perspective of how the pandemic amid which we are living is playing on our mind or our brain, and also what about many of those patients who are getting brain stroke related issues during this pandemic, and how they are going to get that healthcare which is unavoidable, not cannot be delayed, and has to be sought on emergency manner. So over to you, Dr. Padma, with your talk.
Thank you, Dr. Narayan. And let me start off saying that, in fact, I was there even in your earlier session, and I was listening to all the panelists, electrifying discussion. And after that, scintillating presentation by Dr. Divakar, absolutely, I was left speechless. So, but it's going to be a paradigm shift from what we've been discussing, I guess, from the afternoon onwards. So I'm taking you straight to the COVID area, and from a frontline worker, because I have COVID posting. So I'm completely shifting the focus to a completely clinical discussion, and take you through a short journey of going beyond fever and cough and chills and sore throat and what has been defining the COVID. And, let's look at what's the COVID and what's been its impact on the brain. Now with 10 million cases data that we have globally, we've gone beyond this so-called respiratory, thing. So I'll share my screen. Where in the world is this? One moment.
Imani, please help doctor to get the screen share.
There's a green button on the Zoom which says screen share.
Yeah, I have, but it's not figuring in this. So I was trying to see where exactly is it. One moment.
So while we wait Dr. Padma to share her screen and start her talk, I would also like to request our audience that on this Gratitude Week, we are running a campaign to demand and to request our government as well as industry and civil societies to come together and help setting up a memorial for our healthcare workers, the millions of healthcare workers who are working tirelessly for during this time of the pandemic, but they have always been working and ensuring that the supply of essential healthcare, medicines, diagnostics, and many other technologies which are required to make people healthier during this time of during the diseases or to make them healthy are reaching to us. So now I think Dr. Padma has got her presentation ready.
Okay, right. All right. Thanks for waiting. So here we are. We're going to talk a little bit about what the COVID impact is being on our nervous system. So a little recap. I'm not going into COVID. We've heard about this COVID and the pandemics and how it started, and Wuhan and China and so on and so forth. So I'm not getting into that, except to say that as relevant to the nervous system impact, that you have these ACE2 receptors, which are common. The first SARS thing, which hit us in 2003 and now. And there's been a lot of commonality, which was even earlier discovered, that there's been an impact on the cardiovascular aspects of, in general, the vascular outcomes with these pandemics. So this has always been known, except that with this COVID-19, it's just, in fact, I think it's gone beyond anybody's imagination. So there has been a term, where illusions turn into, just realities, and realities just illusions. So this constant metamorphosis which is surrounding the COVID pandemic and our knowledge and our literature, and if you look at the publications, every week there is something appearing in NEJM and Lancet and then getting withdrawn. So this really never happened in the history. So this is something else. So the entry into human cells, again, you have the spike protein, and this has been the focus for reasons more than one, including the fact that there's been mutations now. And I think just 2 hours ago, we've had another report coming that why the infectivity is different and why we are having a surge again, and why the surge is different. It's something to do with the mutations here. And more importantly is that it is the focus for the development of vaccines. So in the global distribution of COVID-19, what, most of the literature which we have is that 40,000 data, which initially came from Wuhan, China, and then went on to few bits and spurts, not in that amount of 40,000, but something trickling from Europe and something which trickled in from the US, and something is now trickling in. In fact, from our own department, we've had some publications on the COVID aspects. Said that with 10 million cases, and you have 5 lakh mortality globally, and of course, Indian figures are also rising. So with this, what we have known is one aspect, and what we're continuing to learn, the learning curves is seemingly just getting steeper. So that's the uniqueness of this aspect. So the initial manifestations, or the Conan drum, which sort of defined COVID-19, was only this, and it continues to be this. This is like, our take-home message, how do you recognize? And it would always turn out to be influenza-like illness. And then it turns out to be SARI, or a severe acute respiratory illness. So influenza-like illness. So you have fever, cough, and then things which are red flags where you need to definitely reach out is when you feel breathless, and you have this extreme fatigue, and you can't talk or you can't walk without feeling breathless, or you have a chest pain. So this continues to be there. These percentage probably continues to hold true, but then a lot more has been discovered, and that's where we have evolved, and that's where brain has come in. The diagnosis of COVID-19, we know about it, but what is being practical, what is being practiced, I'm talking to you from complete and hands-on experience, what we do in AIIMS Delhi in our red area, which is our emergency, or the ER, which is common for COVID and non-COVID. So if you have a COVID suspect and the suspicion is pretty high, then we have a rapid antigen which gives you the result in 15 minutes. So if that is positive, then it is positive. Then they get just shipped into a COVID designate center, which is our trauma center, which has been converted into COVID designate. And then you have, for any intervention, and in fact any emergency, and any of those situations where I need to do a CT angiogram, or I need to do a cath, I need to give an injection, like say for example treating a stroke patient, then I do CBNAT or the TrueNAT. Now the CBNAT and TrueNAT gives you the result in 2 hours. So that gives you the time for an intervention, and at the same time gives you the precautionary aspect, so that if they're positive, they're getting into designate, they're negative, then they get into these interventions in the non-COVID area. And in those situations where you can wait for 8 to 10 to 12 hours, there's still COVID suspects, we do the RT-PCR, the nasopharyngeal lab, the swab, and then they're shifted to a COVID suspect, what we call as a holding area. Now, actually, I'm giving you the blueprint of how these cases are being managed, because, ladies and gentlemen, we now have a mix of COVID and non-COVID. There's no longer a clear distinction, because we have a whole lot of asymptomatic who can just be an asymptomatic COVID, but have present with other non-COVID illnesses. Remember, besides COVID, there are a whole lot of illnesses which are continuing to happen. As Mr. Narayan is it was so important that he brought out this, that, becoming completely COVID-centric doesn't help. People are dying of cancer, of MI, of stroke, or what have you. So those guys are also there. And you need to know this, because if they are COVID positive, then you need to sanitize the entire spectrum of your CT scan, your MRI, your corridors, your lifts, and then send a whole bunch of healthcare workers to quarantine. And you don't want to do that, because you already have, a severe restriction of personal infrastructure in dealing with this pandemic, and that's global. So looking beyond fever and cough, we are looking at the neurological aspects of COVID, and that's the topic I would like to talk to you about. That when this emerged from Wuhan, and at that time as well, there was definitively a neuro-invasive potential, and also the nervous system getting implicated, even if it is not invading the brain, in a different way. And you now know that the largest organ that the virus seems to impact is what is called as endothelium. You all know that the endothelium is the biggest organ. The largest organ that we have in our body is the endothelium. And it impacts endothelium. No wonder you have these vascular outcomes in terms of pulmonary thromboembolism, or heart attacks, or brain attacks, and what have you, kidney and gastrointestinal systems. So this is how we are evolving. And the neuroinfection initially, they did suspect because of, in the flu screen, that anosmia, agutia were both there. Anosmia in terms of lack of smell, agutia in terms of lack of taste. Now, when you have these as a complaint, and they can be standalone red flags to suspect a COVID, and it happens. So it implicates that a peripheral nervous system is already got involved, and that's how the person is presenting with a COVID as a anosmia agutia. So this was there earlier. And this was also known that the respiratory involvement, that is the thing of dyspnea or breathlessness, was not only because the lungs are involved, it also could be because of the respiratory system getting involved within the nervous system. Even that has been thought about. And we'll come back to these things a little more in detail, a little more up close and personal in the next few slides. Okay, so do we have an evidence of this? Yes, we do have a whole lot of evidence which has started to come into the literature gamut, something like from April onwards this year. The first one it appeared in JAMA, where in admitted patients, so you have COVID, you have this severe COVID, they got admitted, and while being admitted, they found that almost 40% can have some kind of a neurological problem. So they could have central nervous system or a peripheral nervous system, or they could have myalgias. Why? Because remember, the ACE2 receptors, they are distributed all across. They are there in the skeletal muscles, they are there in the brain, they are there in the gastrointestinal system. So they are there everywhere. So wherever they are, so obviously those complaints would come in. It is not just only respiratory epithelium. So these were seen that patients could just have headache, could have dizziness, various degrees of impaired consciousness, strokes, which I will be definitely dealing with in much more detail, seizures, imbalance, as I said before, anosmia agutia, a lot of post-viral problems, a host of post-viral problems, which includes AIIMS, which includes neuropathies, Guillain-Barré syndrome, and of course, muscle injuries. This is one of those, representative films wherein the CT shows these black things, which are strokes, and the peripheral ground glass appearance suggesting a COVID lung. So this was there. And were there any lab findings which, up your antenna? Oh, okay, so this guy may be having a nervous system. So lymphopenia is known, and in these patients, we've found that the lymphopenia is even more marked. Low platelets and the urea creat were high. And this was also brought out in another publication from Lancet in 221 patients this time who were admitted. They found nearly 6% who developed strokes in the hospital while being looked after for their pneumonia. So during hospital admission, while either recovering or while on ventilator, they developed strokes. And sometimes when they were recovering, they could understand why these thromboembolic phenomena were happening. And in their series, they were more of ischemic rather than bleeds. And that also actually has changed, because in our series from AIIMS Delhi, we have 13 strokes so far documented. The first 2 strokes were bleeds in the brain. And we have already published this in the process of publishing the other 13. And this was another publication, 52 critically ill patients. And here, look at the mean age. They're not old. They're really not old. 60 years, 55 years, 45 years. And in that group as well, 40% had an underlying comorbid illness. So this is also now known that those people who contract, the potential or their potency in getting the infection is also more in slightly older and with comorbid. Plus, once they are infected, they are the ones who lead to severity of illness and also more chance of having severe morbidity and mortality. That we know. That is more or less established as against, the younger lot. And similar things has appeared, for want of time, for saving time. So I don't want to get into detail, but a lot of these publications had come from China, which kept on highlighting the fact that there were a lot of strokes and a lot of neurological problems that they kept noticing. But what was more important is that, besides the fact that they had a lot of comorbid conditions, and you could explain that, they're okay, you make them into central nervous system, peripheral nervous system, skeletal muscle. There were 15% of severe cases. They came out of ventilator. They were no longer hypoxic, but they continued to be in altered sensorium. So one could not really, tell why they continue to be in this state of delirium, in status of various shifts of coma, in spite of the other issues being okay. That's when they went on to do MRI, they went on to do EEG, and they found that there was a diffuse encephalopathy, which seems to be as though the virus has directly implicated. Now, 8 days ago, we got the first confirmatory proof that yes, they actually found the signatures of the COVID-19 in the frontal lobe of an autopsy. Now, for reasons more than one, you all will understand why we don't have too many autopsies, why we don't have too many neuroimaging. Just imagine, MRI you do for a COVID positive, you need to sanitize that machine for the next 12 hours or 24 hours. So it's difficult to get these tests done. So, but now since the data is increasing, we are able to get more proof. Okay, so apart from strokes, these encephalopathies and all the others, the other thing that they found is that the median time of the occurrence of these seem to be in the first 1 to 2 days. And even in those earlier publications, they found that some of them didn't come with fever or cough. They just presented with acute stroke and then went on to develop lung lesions. Then COVID was suspected. So therein lies the problem. You don't suspect COVID. The person is a 45-year-old hypertensive, came with sudden onset of right hemiparesis. That is it. You don't suspect COVID there. But after you've done whatever you had to, patient is in a non-COVID area, then he goes on to, when you do a CT, you get these ground glass appearance, you wonder why. And then you do a COVID test and it's positive. And just imagine the exposure, the patient himself, as well as the patient's attendants, the healthcare workers and the systems, which would then be contaminated and would need to be sanitized, or there's a risk. So these are the factors and these are the situations which now we are seeing, and we have evolved systems to be able to take care of them. And that's what I'm going to tell you now. So the lab findings, as I said before, TLC lymphocyte counts, but more importantly, we've also evolved a panel of biomarkers which will again highlight the importance of the involvement of other systems other than just the lung. And that would include D-dimer, CRP, and the D-dimer and the TROP as well. But the most importantly, D-dimer would indicate a consumptive coagulation. So besides the, the term, you all must have heard about the term called cytokine storm, which actually is a killer. So besides certain biomarkers, say for example, IL-6 levels, those, besides that, D-dimer is something which you can very easily do in a lot of clinical practice settings. And this would be important to indicate again the other organs being involved in COVID. Okay, so this sort of summarizes all the neurological issues which can happen with COVID, which can be extremely non-specific like headache, malaise, fatigue, to the specific ones like loss of smell and loss of taste. Definitely acute stroke. This is turning out to be one of the very common presentations now. When you're looking at the chunk of respiratory issues in COVID, plus of course even encephalitis, meningitis, AIIMS, and seizures and autoimmune phenomena and others. And why is it so? So one is, of course, we alluded to earlier that it is the ACE2 receptor which becomes sort of the entry point. And wherever these ACE2 receptors are there, those systems can be involved. Then the second is that some autopsy results earlier, did say only hyperemic and edematous, but 8 days ago, we had the first report where they found these signatures in the frontal lobe, and one CSF report came out positive. Okay? The other is that we have some evidence that even the other, the SARS viruses did enter CNS, but far less in number. We didn't have these kind of humongous numbers they were not really pandemics as such. Neither the SARS earlier or the MERS, they were just epidemics. D-dimers, as I said before, which would indicate a consumptive coagulopathy. Immune suppression was another one. Then we also have this harmful immune response, what we call as a cytokine storm, which seems to be the reason for most of the mortalities. And that's one of those arms wherein our armamentarium is involved in coping up with the severe COVID patient. And multiple metabolic issues, hypoxia, acidosis, multi-organ dysfunction, sepsis, and even medications. You know about placing a patient in a prone position to be able to deal with pneumonia in the severe COVID respiratory illness. And to make a person prone, you need to sedate them. So while they're sedated, you can't look at, they're encephalopathic. So there's a lot of medications which cause that. So in COVID-19, and if you look at stroke per se, the earlier reports said that they're mostly ischemic, and they could be CVST, arterial, venous, yes, some, and various varieties. Later on, we also found that they can happen in young people, no risk factors. In fact, people would be sent home saying that this is a mild illness. They go home and quietly die there because of an arrhythmia or because of a sudden myocarditis or an AMI, that is, MI, that is acute coronary event. Or even they found large artery strokes in young people, and these reports came from the United States, somewhere around May, June. And now we're seeing that there was one study which also showed lacunar, the small strokes which have been reported. And in our series of 13 patients, we found a lot of them turning out to be bleeds rather than mere ischemic events. So the implications of heart and the brain have also been correlated with as to why there could be a clot in the brain. Maybe because there is multiple issues in which the myocardium is involved, including this destabilization of an already existing plaque. Remember, they all are generally people with a comorbid illness. Although there is a small segment of young people with no vascular problems, but majority are these 40, 45, 50, 55 with diabetes, hypertension, underlying, other diseases and malignancy. So the risk factors among patients with COVID, age and comorbidities, and other risk factors which predispose to patients to develop an incidental stroke or infective process could potentially trigger the same. And inflammation per se can trigger a vascular event, whether it is heart attack or a brain attack. This has also been known. And the cytokine storm, that what are we doing these days? We are actually measuring IL-6. And when this is actually increasing, even before we preempt this problem and immediately start them on tocilizumab or one of those medications. So these are all in those armamentariums now, and we didn't have them probably in January or February. Now you have them in your kit, in any of those, in the ICUs where you deal with them. It's also known to be a prothrombotic situations. APLA, a lot of APLA as a biomarker has also emerged. So now in the routine practice, a lot of them are put on heparin. Whenever the D-dimer is raised, you're actually anticoagulating them. So this is actually coming to the arm of an intervention, because these things have been increasingly noticed, and they are being recognized and now accepted as one of the phenomena in the pathogenesis of these vascular outcomes. Also, these, the infections can cause them. And so these are the two take-home slides for neurological problems, that neurologic conditions associated with COVID could be encephalopathy, encephalitis, meningitis, stroke, peripheral nervous system, AIIMS, Guillain-Barré syndrome, lot of neuropathies, muscle injury. There's a way how they present, the neurodiagnostic things which are required, and the presumed pathogenesis. And this is the cartoon which actually says that systemically it can involve, direct central nervous system invasion it can have, peripheral nervous system, and post-infection also immune mediated you can have these conditions. But one, what Mr. Narayanan had said, while all this is being done, a normal stroke can happen. And it's actually, I see in my statistics, we have a whole lot of strokes. But what happened during lockdown was, in initial Feb, March, April, and we got out a publication on this, we looked at the number of strokes, and there were a global presentation as well, that 30-40% reduction in the number of strokes which came to our emergencies. Now these were, it's not that the strokes were not happening, but just the minor strokes were ignored. People couldn't have an accessibility, availability, affordability, nothing. Lockdown, no transport. Second, even if they did take the patient somewhere, all the health infrastructure was all COVID-centric. So you go to a place and they would say, oh, we're dealing with COVID patients. You go to a non-COVID center. The non-COVID were limited. And even if the patient had gone, the healthcare systems were sort of, they were not very happy to deal with them. There was no time for them. And patients and caregivers were afraid to go to a health system because they were very worried that they would catch the infection. So there were umpteen number of reasons why a non-COVID emergency could not be entertained, was not entertained. We didn't have a data coming in. This was published. And now we've seen that even the compliance of vascular risk factors, what was happening in this last 3-4 months? Who cared for their hypertension, diabetes? What's happening to all these people sitting at home, staying at home? What is happening to their compliance? Where they be able to get those medications to treat their diabetes and hypertension? God knows. So I really don't know in the next few months whether we get an avalanche of all these non-communicable disorders turning out into a big, when it would all rain, these vascular events, because now we're seeing more strokes. So therefore, we got out what is called as a protected couch stroke, wherein supposing there is a stroke patient who comes in, what do we do? So the most important thing here is that you need to have a designated place with a designated personnel, and we have the personal protection equipment, and we need to have a role designation and all the procedures which increase the aerosol. Like normally when there is a stroke patient, there is a big team which comes in. We have a very low threshold to get an MRI. We're not doing all that.
So thank you so much, Dr. Padma. The one important aspect here which I want to highlight you, that you are fighting COVID-19 on the front line. You are taking care of the COVID, the stroke as well as the all neurological patients in the apex institution of AIIMS. And I'm sure that it has been a very, very difficult time for you also to manage, all this at a time when there are a lot of concern and challenges and the constraint doctors are operating in. So my salute and the salute from the entire ISW Council for you, for your wonderful work, for your efforts which you are putting together. And this gratitude marathon is meant to highlight the challenges and the effort which you people are doing. I'm really honored that you joined us today.